Hello.
Yeah, but everything is stretched out. So, are we live or
No, we are just started live. Hello. You want us to hold?
okay? No, no, it's okay, fine. So we are starting, right?
Yes, yes, yes. I think your video
Uh,
is in off.
Good afternoon. Uh, at least I'm audible.
Yes, yes, yes. Uh,
Okay, fine. So, good afternoon, friends. Myself, Dr. Parsha. I am from Ahmedabad, practicing fetal medicine consultant. So today we are going to start a webinar in the aegis of President Dr. Alpesh Gandhi and the chairperson, whole post holding in Foxy, Jaideep Taksar. Our first speaker is Dr. Ashok Kurana sir. He is well-known speaker. He is well-known teacher of all the obstetrician as well as radiologist. He is running his center in Delhi, and he is teacher of not only the Indians, but he is getting lot of students from abroad also. So I would like to hand over the mic to Dr. Kurana sir, and he will start the session.
Thank you. Thank you very much, Dr. Parth. And my thanks also, while I begin my screen share, um, to Foxy for partnering with the Society of Fetal Medicine so that we can be here today together for things that are dear to our heart. And I hope my full screen is now seen. If I can get an input from either Dr. Parth or from Basu.
Yes, sir.
Are
Your
you able
screen
to
is
see my
live
full
and
screen
we can
now?
see you nicely. Yes, sir.
Yes? Yeah. So my thanks to Foxy for partnering with the Society of Fetal Medicine. We have a common aim here, which is to give every fetus an optimal outcome and also to contribute in the best possible way to make obstetric, ultrasound and obstetric care as well as pregnancy and fetal care available to every single woman in our part of the world. Our topic today is NIPT, non-invasive prenatal testing, goes by several names, and I would leave it to Dr. Ratnapuri, expert from today, to tell us how we should be using this today. I'd like to introduce this topic with taking you into a brief history of the origins of current fetal medicine. We know that the story started by just a simple look that we needed to do for the neural tube defects, where we used to do a dating scan in the 70s and the 80s at 14 weeks, which was called a level 1. And then we went on to assess maternal serum alpha fetoprotein if she was 14 weeks. And the ones with the raised level used to come back for a level 2 scan at 16 weeks to look for open neural tube defects. We've come a long way since then. We've realized that simple maternal serum alpha fetoprotein combined with a thick nuchal skin fold, if it was going in the opposite direction, that means a low maternal serum alpha fetoprotein, would actually be an indicator for Down syndrome. And we had major revelations because Down syndrome is one condition for which there is no cure. It results in the compromise of cognitive abilities and intelligence as well as other physical defects, and is the most common congenital cause for mental disabilities in the human population. Of course, the test evolved when we went on to then dismiss the triple test because it wasn't good enough, and onto the quadruple, and all in search of a good test for the antenatal diagnosis of Down syndrome. We then went on to first trimester screening, and finally on to what we're going to discuss today, which is non-invasive prenatal testing. And so all of this changed, and we did realize that we'd thrown the triple out of the window for Down syndrome simply because the detection rate was only about 65%, and we need at least a 75% to be able to actually make it acceptable. And so we went on to reach that with the help of combined testing. And the good news then was that about 8-9 years ago, we got cell-free fetal DNA to come along. It goes by various commercial names, but the important thing is that it works pretty well for trisomy 21. And Dr. Ratnapuri will give us the background on that today, as well as tell you how we should put it into practical use. We have to be aware of something, and we have to be aware of the fact that beyond science there is commerce. We have to accept the fact that healthcare today is not about healing and is not about doctors practicing their professionalism. Today, healthcare is in the hands of the management people, which means they have a background in business and they do business management. And because we have reports like this floating in the market, which talk about market size, test analysis, country outlook, we realize that we can be taken for a fair ride. The market information that we get from these reports is that the revenue by 2025 from NIPT is close to $5,000 million. Believe me, that's one of the largest industries in the world for 2025. They talk about market statistics where they say that, okay, there's going to be 250,000 families in the US affected by Down syndrome, which is correct, which is understood, which is what you and me are working to give patients an option on how they want their reproductive outcomes to be. They then also talk about things that are alien to us, but which we must know, because this is what has driven industry straight away from you and me to bypass us, and they started marketing directly to the patient. Luckily for us in India, we did not permit this for too long. We put our foot down and put our own checks and balances and said no genetic testing will be done without a prescription from a qualified person who is then able to guide the patient to a laboratory where the test will be done by a PCPNDT registered organization. And therefore, we've been able to get control of this all in the right time. And therefore, we have no misuse in India today of the NIPT. But we are still driven by the fact that these people are trying to market straight to say, for instance, that, look, come, we want more people to come in. The major players are there, now come and join them. And then we will bring the cost down, and that is how we will break even. Or that if we do 100 tests per day, we will manage to break even at a very ridiculously low cost. We must not accept this. We must say that, look, we will do the test where it is required. And this afternoon, over the next 40-45 minutes, Dr. Ratnapuri will guide us through that. We thought ultrasound would be out of the way, and as you will learn today, for a good result from NIPT, we do need to have a good fetal fraction. And to get that fetal fraction, we have to ensure that A, the fetus is alive, that the fetus is large enough, and the lower limit is 10 week size. And how will we date that? Not by the LMP, we will have to date that with the help of an ultrasound scan. And then we must know the number of fetuses for the answer, and that again is an ultrasound scan, and whether the fetus is alive or not, so that's an ultrasound scan. So therefore, then we do realize that NIPT has worked the other way to actually make ultrasound more relevant. And as usual, then we continue to go beyond the dating of pregnancy and confirm number and viability. And we also add on other things which then make it much more viable. And that is that although the incidence of Down syndrome is 1 in about 1,000, the incidence of other things that we can check at this first trimester scan, which is preeclampsia, growth restriction, and preterm birth, makes the whole exercise worth it. So therefore, we now start with an ultrasound scan, add an NIPT wherever necessary, and we will discuss how best this is done. Because we do realize that although NIPT is becoming extremely fancy, the moment we go beyond the common autosomal trisomies and we go beyond the sex chromosomal aneuploidies, the whole trend begins to fall. Microdeletions, some not so validated, and detection rates poor. Genome-wide assessment with its own problems, and we will discuss those. And single gene disorders right at the bottom, and we will discuss those. Also, we understand that the simplicity of counseling goes down when we go down this. The degree of performance goes down. The evidence in performance is also down. The prevalence is also down, and the clinical relevance is also down. And I do hope that we will understand at the end of this how to use it correctly and what we should be doing. So with those words, I will then hand over the screen to Dr. Ratnapuri. She does not need any introduction to all of us. We know that she is chief of the Institute of Genomics at the Sir Gangaram Hospital, Institute of Medical Research in New Delhi. But more than that, she is now a household word for every professional working with fetal healthcare. We know that she is a phone call away, she's an email away, she's also a single touch lab away, which means we have a problem today, we say, what do I do next? She will guide you. And we hope to hear from her how best we can now sort out this conundrum of NIPT and how we should use it today. Dr. Ratnapuri.
Thank you very much, Dr. Khurana, for the very kind introduction. It is a pleasure to be here. And thank you very much to Foxy and, as always, the Fetal Medicine Foundation, the Society of Fetal Medicine, for this opportunity to take it forward. So what I'm going to be talking on today is non-invasive prenatal testing and how should we use it. And that's the key thing here. Now, this is very familiar to everybody, I think, through the length and breadth of the country. And I think we have to thank our commercial partners and our companies who have really taken it to every city. Am I heard well before I proceed? Hello?
Yes, madam, you are,
Okay.
you are audible, madam.
Okay, thank you. So before I move into the details of NIPT, I'm just going to give a little introduction about what all this is, where does it come from? And we need to understand that we have 23 pairs of chromosomes, that's the central dogma, and all these chromosomes lie within the nucleus. And when we talk about abnormalities of chromosomes, they are abnormalities of number. So aneuploidy is an abnormality of number, like it could be a trisomy or a monosomy. A triploidy is where all the 23 pairs are one chromosome extra, and a normal karyotype has 46 chromosomes. So these are various kinds of abnormalities of number. An example of the trisomy is the commonest trisomy 21 and also includes 13 and 18, and Klinefelter syndrome, XXY, which is a kind of a sex chromosomal abnormality, though it's not within the group of a trisomy, but there are one additional chromosome X there. And then we have the monosomy, where the commonest one is the Turner syndrome.
Dr. Ratnapuri, sorry to interrupt, but we have a few requests. If you could be just a little louder, they're not able to fix that technically. My apologies. Perhaps closer to the mic. Yes.
Yeah, I will do that.
Thank you.
Okay. And then we have the monosomy, which is Turner syndrome. So all these come within the abnormalities of number. Then we have the abnormalities of structure, where within the chromosome, the number is fine, but the structure is abnormal. If the number is fine and the structure is balanced, as in this case, it will not cause a problem. The problem happens when it is unbalanced and we have some additional either deletion or an additional duplication of part of the genomic material. Am I okay now? Am I audible?
Yes, thank you very much.
Okay, thank you. So these are important concepts to understand before we really go into the realm of non-invasive prenatal testing. Now, traditionally, aneuploidy screening has been done for chromosome 21. The reason for this is that it has a high prevalence, and in India we have data for this to tell us that 1 in 900 to about 1,000 children born, one of them would have Down syndrome. Now, as a consequence of screening for Down syndrome, and you heard the introduction to that by Dr. Khurana, it was also identified that we could figure out that if there is any abnormality related to chromosome 13 and 18. But we also know that the prevalence of these two disorders is much lower. And if we compare it to Down syndrome, for 18 it is 1 in 3 with relevance to trisomy 21, and for trisomy 13 it is 1 in 7. The various tests for screening for trisomy 21, 13 and 18 have progressively improved and have been enhanced over the years. I'm not going to go into these details. We know that there is in the first trimester the combined screen. The detection rate for the false positive rates are above. We can integrate the first and the second trimester. The triple test, as Dr. Khurana said, has been thrown out of the window for poor detection rate. And if we just add on inhibin, you get the quadruple with a much higher detection rate of up to 80 to 85%. And then we can combine markers in the first and the second trimester. So this has been, and this is what we are going to refer to as the traditional screening. And if you see at the end, we have the cell-free fetal DNA, which is also a form of screening for aneuploidies with a very high detection rate for trisomy 21 of greater than 99%. So we know what the trends are in India. Predominantly, most of our women come in the second trimester. So you offer them the level 2 scan and the quadruple screen. If they come in the first trimester, it is best to offer them the combined first trimester screen, which you could combine with the preeclampsia test and give them an overall outlook as to how the pregnancy is going to be. Now, we come into what the non-invasive prenatal testing, which is essentially cell-free fetal DNA that is present in the maternal plasma. It was identified way back in 1997 and became commercially available in 2011 for aneuploidy screening. We also, before that, were able to do the Rh genotype of the fetus, where you have an Rh negative mother and an Rh positive father. And this technology has also been used for single gene disorders, and we'll be alluding to this a little later. Now, this cell-free fetal DNA is DNA that is present in the cells. We know that most of the DNA is present inside the cells, in the nucleus of the cells. This is different because this is free-floating DNA that is present in the maternal plasma. It has two origins. It could come from the placenta and indirectly represent the fetus, and also it is of maternal origin. So all the cell-free fetal DNA in the mother's blood has two origins, maternal and placental. The placental represents the fetus, so it's important to remember that. 2 to 20% of the maternal DNA is of fetal or placental in origin. We can identify it in the maternal blood after about 7 to 9 weeks of pregnancy. And once the baby is delivered at term, the fetal this DNA disappears from the blood postpartum. So there is no risk that in a second pregnancy, the fetal free DNA that is present in the maternal blood actually represents that from the first pregnancy. Now, if we look at this chart where we talk about screening, remember I told you that NIPT is a screening test. And here we go forward. It is a very, very high efficiency test. But it still is not a diagnostic test, because a diagnostic test gives us a definite answer. It tells us yes or no. And this is only when we actually visualize the fetal chromosomes, where a sample of the fetus is taken either by a chorionic villus sampling or an amniocentesis. Now, if we compare traditional screening to cell-free fetal DNA, and remember I told you that traditional screening is the combined first trimester screen, or the quadruple, or the integrated, or the contingent screen. We know that the cell-free fetal DNA is the most sensitive and specific screen, and with a very low false positive rate compared to traditional screening, which has variable sensitivities depending upon the kind of test that you're doing, and it varies from 80 to about 92%. The positive predictive value varies according to the prevalence, and if we're doing a cell-free fetal DNA in low-risk population, that means in every woman who's pregnant, it has a positive predictive value of 45% compared to that of only 10 to 20% of the traditional screening. And if we apply the cell-free fetal DNA to high-risk women, it has a very good positive predictive value of 90%, which means the possibility that the disorder is actually present is very high. The cell-free fetal DNA has a wider gestational window for screening. You can do it up to term, right from 10 weeks of pregnancy, whereas traditional screening does it only in specific time periods of the first and the second trimester. The advantage of the traditional screening over that of the cell-free fetal DNA, that in addition to aneuploidy, it looks at various other additional things. It is able to look at all the fetal chromosomes, including the abnormalities of number and structure, whereas the cell-free fetal DNA will only look at the abnormalities of number of 5 chromosomes, 21, 13, 18, and the sex chromosomes. Traditional screening also will give you a risk for preeclampsia, growth restriction, neural tube defects, and some genetic disorders related to low E3 levels like Smith-Lemli-Opitz syndrome and steroid sulfatase deficiency. So you can see that both these forms of screening have advantages as well as disadvantages, and no one form is absolutely perfect. So what are the models that are available for us for use? We can do a primary first trimester screen. That means the lady comes to you and you say, okay, let's do the first trimester screen and then take it forward. You can do a contingent. That means you've done the first trimester screen. It comes as a high or an intermediate risk, and then you do the NIPT. Or you see some ultrasound markers for aneuploidy and then do NIPT. Or you can also do it in situations where the lady has one child with trisomy 21, the risk of recurrence is 1%, and there you could use the NIPT to evaluate for that risk of recurrence. So whichever model you use, no one model is perfect, and that's the key thing to understand. We need to understand the different models. We need to have a good awareness and knowledge of NIPT prior to the use. And very, very importantly, we need to understand the cost. We need to know that we are looking primarily at one disorder, Down syndrome, at a cost of the NIPT test. And it requires good pre and post-test counseling. And it is these last 3 things that I'm going to focus on in the rest of my talk, so that at the end, it's not I who is telling you what to do. I hope that I'm able to give you the advantage of being able to decide for your patient which is the best form of screening for that particular patient in the clinical scenario that is present. So we are going to answer 8 questions through this talk, and I'm going to take them one by one. What are the prerequisites for NIPT? Should we use it as a primary screen for all pregnant women or contingent to a positive traditional screen? Is there any role of ultrasound? Is the family history important? What gestation should the NIPT be done? What do we do if an NIPT screen comes positive? What happens when you get a result like uninterpretable or no call? And does NIPT exclude all genetic disorders? So the prerequisites for NIPT are good pre-test counseling. And what does that entail? You have to see the case and review to decide if the patient should be offered invasive testing or NIPT. You need to take the detailed family history for evaluation. A baseline ultrasound examination either in the first trimester or the second trimester whenever the lady presents to you is imperative. You need to tell the family that the NIPT is only going to give us information of 5 chromosomes, and that also related to abnormalities of number. It does not touch upon abnormalities of structure at all. That it is not a diagnostic test, but a very high efficiency screening test. It only tests for specific chromosomes, and it does not exclude other abnormalities. It has a turnaround time, so you're not going to offer NIPT at 19 or 20 weeks. It gives a result as a high risk or a low risk or a negative or a positive. If it is positive or high risk, it has to be confirmed with an invasive test. It could be either an amnio or a CVS. If it is low risk, the pregnancy has to be followed up with routine antenatal care. So these are the components that are essential for pre-test counseling. Now, how are we going to decide whether we use it as a primary screen at the first visit of the pregnant lady, or are we going to use NIPT as contingent to a positive traditional aneuploidy screen? For this, it's important to understand that we have 3 terms. There is a detection rate. The detection rate is 99.7% for trisomy 21, and these are for NIPT. It has a very, very low false positive rate. So these are the 2 big advantages of NIPT. Because if we do even the first trimester combined screen and we use all the markers the detection rate does not go beyond 92% for a false positive rate of 3 to 5%. And then we have something that is referred to as the specificity, which means that if the NIPT comes low risk, what is the probability that the child does not have Down syndrome? And to my mind, this is a very important point, and it is as high as 99.9%. If we look beyond for trisomy 18 and 13, these figures go down, and it's the least for monosomy X, and we'll understand subsequently why this is so. So remember, that's why NIPT was traditionally made for trisomy 21, and everything else has piggybacked onto that. One thing is very clear, that all women will be offered aneuploidy screening during pregnancy, and I think all of us across board will agree with this statement. But what form of aneuploidy testing or screening are we going to offer them? Are we going to offer all NIPT? So herein comes the importance of understanding the sensitivity and specificity of all the screening tests, the relevance of a false positive and a false negative. And here I would like to introduce the latest ACOG guidelines, which are really not in print, but there's only a podcast which introduces us to the concepts that are within these guidelines that have come into, it's available online in August 2020. Now this says that screening and diagnostic testing for chromosomal aneuploidy should be discussed and offered to all patients. This is very, very important, and this is a big change from the previous guidelines, which told us very clearly that you do the traditional screening first. If the traditional screening is high risk, then you either offer NIPT or you offer diagnostic testing. So this is a big change. The reason for this is that this is a very personal nature of decision making for the family at stake. A family may not want to take a chance for trisomy 21, and if a test is available, they would want to test non-invasively by NIPT. Another family would say, you have a test where I could exclude all chromosomal abnormalities by chromosomal microarray assay. I'm happy to do an invasive screen and exclude at least one lot of disorders that are possible. So this is what it means, that there is a personal nature to decision making. But what is very important is that these points should be discussed early in pregnancy so that there is enough time in pregnancy to take these decisions forward. It's important to note that there is an inefficiency of screening of all forms of screening, whether it is the traditional screening or it is NIPT. So that is why it is important that various modalities can be used in different clinical settings. This is what the ACOG guidelines say. How do we apply them to India? We deal with a very heterogeneous population. I don't think we can. Very often the patients tell us, doctor, you decide for us. Of course, we don't decide for them, but we would need to assist them in making the decisions, because everybody and every patient may not understand the intricacies of all these tests. But at the same time, in my mind, it is very important that you don't force any kind of screening test on them. That is something that should not be done. Very often we say, get this done, and until you get it done, don't come back to me. No counseling for any kind of genetic test should be done like that. So you have the world to offer your patient. Traditional screening, NIPT, or invasive testing. Everything has its strengths. Everything has its limitations. Amongst the screening tests, no test is more superior to the other in all aspects. And it is very important that for NIPT and for Down syndrome, we do not lose sight of the other important pregnancy-related issues. And I'm going to take my thoughts through with a couple of cases. So this is a lady, low-risk situation, primigravida, no family history. She conceives 1 year into her pregnancy. The scan, first trimester scan is normal, but she test screen positive in the combined screen. and she has a risk of 1 in 200. The gestation at which she consults you is 14 weeks. You would counsel her. You would start with trying to make them understand what is trisomy 21. I realize we talk about big things, and after we have told them about NIPT, we've told them about invasive testing, they will say, Doctor, can you tell me what is trisomy 21? What does it mean? So you have to give them the implications that it is associated with intellectual disability, but it doesn't mean that the child doesn't learn anything. The child learns, just that he is a little behind his peers. So you don't paint a rosy picture, and also you don't paint a dismal picture, because you would come across families who would want to continue the pregnancy despite having confirmed that their baby has trisomy 21. You have to explain to them what a positive screen means. It doesn't mean that the child has a problem. It just means that there is a probability that the child could have a problem, and we have a way forward. There are multiple ways forward. You could either do the contingent screening, add on the ultrasound markers, or do an integrated screening with testing second trimester markers at 16 weeks. Or you do a cell-free fetal DNA testing because it has a higher detection rate and a higher sensitivity and specificity compared to the first trimester screen. Or straight away the definitive testing, because that also gives us additional information of looking at the structure and number of other chromosomes beyond the 5 chromosomes. And most importantly, you have to give the couple the cost comparisons. So this is a situation where you would talk to the couple and help them to decide as to what they want to do. Let us compare it to this situation where you have a 40 years old, married for 14 years, multiple IVFs, nothing happened, and then suddenly, many years beyond, she just has a spontaneous conception. And each of us see these situations very often. Her first trimester scan shows a normal nuchal translucency, and she comes in at 14 weeks. You would look into her family history. Is there other history of infertility, recurrent pregnancy loss, or intellectual disability? I would want to know that the karyotype of the couple is normal and we are not dealing with any balanced translocation carrier state. Now this couple went ahead for a NIPT test, and that came back as to be high risk for trisomy 21. It had to be confirmed by amniocentesis at 16 weeks. Trisomy 21 was confirmed, and then we did post-test counseling to talk to the patients as to what they would like to do. We should not take it for granted that everybody would want to discontinue a pregnancy. We come to the next situation. What is the relevance of an ultrasound examination in the era of NIPT, and is a family history important? So there is this recent study which has come out in 2020, when you identify soft markers of aneuploidy in the level 2 ultrasound. And remember, these are not structural malformations. You could either do an NIPT or you could do invasive. They did invasive. So in this study, they either did NIPT or invasive testing with karyotype or microarray. And they identified that only in one situation where there was mild ventricular megaly did they get some additional information when an invasive testing was performed over an NIPT. And the yield is, as you can see here, nearly 5% with a microarray and 3% with a karyotype. We know that in 2 to 3% cases, if there is an abnormality on the scan, we find additional markers in the chromosomal microarray. So, the Society of Maternal Fetal Medicine has recommendations which says that a prior ultrasound is very important whenever you're doing a cell-free fetal DNA analysis. This is because you want the gestational age. You want to make sure that there is viability of the fetus. There is no missed vanishing twin there. You want to know whether it's a singleton or a twin pregnancy, if there is any structural abnormality. And really, you don't do this to assess the aneuploidy risk, because you're already doing another screening test or the NIPT to assess that risk. No diagnostic testing is recommended if further on an isolated soft marker is identified if the cell-free fetal DNA screen is negative. If there is a structural abnormality in the ultrasound, then diagnostic testing and chromosomal array needs to be done. And the series and the guidelines also say no NIPT for microdeletions in the maternal sample. Now look at this family history, and I want to talk to you about the importance of a family history. This is a bad obstetric history. Missed abortion, pregnancies discontinued for malformations, some inkling of some sort of a chromosomal problem, but really nobody got into the details of this. And this, again, the fetus has multiple soft markers, as also a major malformation as a cleft palate and short long bones. In this situation, there was advanced age, bad obstetric history, and a consumer to lab testing, which actually gave us a normal NIPT report. But when we did invasive testing, keeping in view the family history, the fetus actually had an unbalanced chromosomal abnormality between chromosome 10 and 15. And this is something that would not be picked up by an NIPT. So when you have a history like this, where it's not been evaluated, and you have abnormalities on the ultrasound, NIPT is not the test of choice. Here you would want to do an invasive test with either a microarray preferably, otherwise a karyotype. What gestation would you want to do an NIPT, and if it is positive, then what? Look at this case, 16 weeks, she is referred. The 12-week scan is normal. A triple test is done at 18 weeks, and this triple test comes back at a high risk for trisomy 21. An NIPT is done at 19 weeks. It showed a low fetal fraction. A repeat sample is done, and it comes back as a trisomy 18 high risk. She's already 22 weeks by then. The pregnancy, nothing is done because of the fear that there is so much happening. The pregnancy is discontinued. We did the autopsy. There was nothing in the fetus on examination. The karyotype of the fetus was normal. So there are three messages here. Every positive NIPT must be confirmed by invasive testing before a pregnancy is discontinued. No pregnancy is to be discontinued on an abnormal screening test. If you do a postnatal karyotype or a microarray, ensure that you exclude maternal cell contamination because you want to be certain that you're looking at fetal tissue and not maternal tissue. And be wary of when you send your NIPT. If you send it very late in pregnancy, we still have the cutoff of 20 weeks and there is not enough time to work up. So as a rule, please send it early and not after 17 to 18 weeks of gestation. And if after that there's a failed test, do an invasive test because you don't have enough time to work up the NIPT result if it comes as screen positive. Now, this is another case. Primi gravida, IVF was done for a tubal factor. DADC twins with a co-twin demise. This is a situation when an NIPT should not have been done because of this co-twin demise. In any case, the NIPT was done and you got a high risk for trisomy 18. The amniocentesis was done and this was normal. The couple was reassured. The level 2 scan was normal, so there was nothing telling us that it was trisomy 18 because you would have got markers. But at 35 weeks, there was an intrauterine death. And when we did the microarray in the placental tissue, it showed trisomy 18. And this just goes to show that this was confined placental mosaicism because the fetal chromosomes were normal and here the intrauterine death was as a result of confined placental mosaicism. Now this case has been shared to me by my colleague, Dr. Sunitha. It's a very recent case. This was a 6th gravida. The first fetus has a hypoplastic left heart syndrome, but we had done an autopsy, the microarray, karyotype, everything was normal. She had 2 females. Then there was this missed abortions. The couple karyotype was normal. So everything had been worked up, and in this state, she wanted an NIPT because of her advanced maternal age. The NIPT came back as high risk for trisomy 13 and the fetal fraction was adequate. The chorionic villus sampling was done, and in that tissue, in the chorionic villus sample, the fish showed mosaicism for trisomy 13. There were three signals, 30% trisomy 13 and 70% was normal. We went ahead and looked at the karyotype. The CVS karyotype was normal. What could we be dealing with? We could be dealing again with confined placental mosaicism because this was a CV tissue. And just to follow up, when an amniotic fluid studies was done, the fish, the karyotype and the array, we did it all, was all normal. So this is now a normal ongoing pregnancy where the false positive NIPT was as a result of confined placental mosaicism. So there are various causes of false positive NIPT, and these include placental causes and maternal causes. I've talked to you about confined placental mosaicism. Vanishing twin is another one. So when you have a vanishing twin on the ultrasound, an NIPT should not be done. We also have maternal causes that include maternal aneuploidies. The mother could be a triple X, and most of 80% of triple X are asymptomatic, and therefore you never know. But that could give us a false positive NIPT. Some amount of maternal mosaicism also could cause it. Some adults could be silent carriers of microdeletions, including 22q, and that come up as a false positive. And then, of course, we have maternal neoplasms that can give bizarre results on the NIPT, an organ transplant, stem cell transplant, egg donor. These are very important because here you could get false positive results, especially when you use the SNP-based NIPT. But most of us are now using the MPS assay, so we should not worry. What happens when we get something called a no-call or an uninterpretable NIPT result or a failed result? In our experience, all of us would have had some proportion of samples that do not give us a call. It's called a no-call. There are three reasons. Either the blood correction has been inappropriate, we haven't mixed the sample well, it's not been collected in the correct tube because they have special Streck tubes in which the NIPT sample is collected. It could be a low fetal fraction, or it could be an assay failure. We know that when we see NIPT reports, we need to first glance at the fetal fraction. And if the report is at a fetal fraction of less than 3 to 4%, please do not accept it. We also know that the fetal fraction increases with gestational age, so you should not do an NIPT too early. Now, there are certain maternal biology pointers that impact the NIPT performance. One of them is obesity. If you have a lady who's got a very, very high BMI, the fetal fraction is low, and there is a high probability of getting a no-call result. Even if the lady has autoimmune disorders like SLE or any connective tissue disorder and there is clinical disease activity, you can get a no-call. Maternal medications like low molecular weight heparin, it's important to know because these medicines are used very frequently. So you should time the sample collection as far as possible from the most recent dose of the heparin. The other reasons that influence the fetal fraction are multiple pregnancies. Though the total fetal fraction is high in twins or pregnancies, we don't use it for pregnancies that are beyond twins, but the fetal fraction per fetus is less. So the chance of failure in multiple pregnancies is higher. It is also higher if the fetus is a mosaic for a chromosomal abnormality, which means that one cell line has normal chromosomes and one cell line has abnormal chromosomes. Because you see, the amount of abnormal chromosomes is very little. If you have trisomy 18 and 13, usually these disorders are associated with a small placenta and hence your fetal fraction can be low. Now, what is the role of NIPT in twin pregnancies and singleton pregnancies, and does this impact test failure? So the implications here are, we need to understand that NIPT in singleton and twin have similar outcomes. So there is a high chance that you will get a result after the first sampling. The sensitivity for twin pregnancies is very similar to that for singleton pregnancies. So that's the first point. If you have a failed NIPT, a repeat sample will provide a result in half to two-thirds of cases. But it's very important that here you take care of what the gestation is. Most women who have a failed test would have one of these factors: advanced age, the BMI is high, the race is black, nulliparous, DADC twins conceived with IVF. These are factors that have been associated and identified to be associated with test failure. But if you retest them, you can get a result. But it's very important here to counsel the family that even a retest may come back as a failed test. Otherwise, they get a little nervous and they feel that they have, wasted those 10 days or 14 days for a second result to come. So this is very important. And finally, does NIPT exclude all disorders? And I'm really going to show it to you by this actual case where this is a second gravida where the first child had intellectual disability and microcephaly. Very correctly, the child had been evaluated to some extent. The microarray was normal. So we know that there is no chromosomal etiology for the phenotype. But it doesn't exclude all genetic disorders. But because beyond the chromosomes, we know that there are 20,000 genes, and abnormality in one of those 20,000 genes could be responsible for the phenotype. So what happened during the pregnancy of this lady? An NIPT was done. It came back as low risk. In the post-test counseling, she was counseled that the fetus in the ongoing pregnancy will not be affected. The second child, unfortunately, also had microcephaly at birth. So remember that NIPT is not the answer to all genetic disorders. In this family, the NIPT was the inappropriate test to look for recurrence of microcephaly. And whenever there is a positive family history, you have to first evaluate the proband to understand what caused that particular problem before you can guide the family as to what is the best test that needs to be done. Now, I'm just going to take a couple of slides on uncommon things that NIPT is used for. And the first is rare autosomal aneuploidies. And if you remember, one of the last slides that Dr. Khurana showed about the use of aneuploidy for single gene disorders, for rare autosomal aneuploidies, you saw the curve coming down. Now, what are these rare chromosomal disorders? Trisomy 16 and 22. We know that this is not compatible with life and there would be, the loss of cardiac activity. So we don't worry. But mosaic phenotypes, survival has been reported. There are some microdeletions where are checked even now by NIPT, but they are rare. Then there are also situations where genome-wide sequencing is done. That means in the cell-free fetal DNA, they scan the entire genome of the fetus and the mother to look for large deletions and duplications. None of these are recommended by the most latest ACOG guidelines as well, even though that they are commercially available. And the reason for not recommending them is 1, because the prevalence is very low. 2, because of that, there is not enough data about the detection rate and the false positive rate. The positive predictive value for all of these is very low, and that is why you get high false positive rates. We don't even know if that specific abnormality is present. Could it be because of a genetic mechanism called uniparental disomy? Could it be mosaicism, where the outcomes of pregnancy would be normal? So as long as these things are not validated, they are not to be used clinically, and they are also not recommended by the college for use. And here we have the update on twins. I've already alluded to this before, that the performance in twin pregnancies is similar to that as for singleton pregnancies. Cell-free fetal DNA is a much more superior screening test for twins compared to the first trimester or the second trimester traditional screening. And this is really data for trisomy 21. We don't have good data for trisomy 18 and 13, again, because of the very few number of cases that have actually been analyzed in twin pregnancies for these disorders. But remember, it cannot tell us which twin is affected. So if the NIPT is screen positive in twin pregnancies, again we have to do invasive testing for both twins in chorionic and one twin and in the monochorionic pregnancies. And what happens in the context of IVF and this new technology which is now being used in IVF called pre-implantation genetic testing A, which stands for aneuploidy. Now this PGT-A is actually a screening method that is used in IVF pregnancies to enhance embryo transfer. So it is used where there's an advanced maternal age, recurrent pregnancy loss, or recurrent implantation failure, because the clinics want to select the good embryo which will implant well. Again, PGT-A is not a diagnostic test. So even after a PGT-A, you would need to do traditional either screening or NIPT as it is done for pregnancy. A normal PGT-A does not guarantee a chromosomally normal fetus. Yes, we do know that there are risks of low fetal fraction in pregnancies that are conceived by IVF, also because most of them are twin conceptions. And if again you get a failure rate here or you get a high risk on a traditional screen, you would need to do diagnostic testing in these cases, even where the PGT-A has been done, because a PGT-A is not a diagnostic test. So to wrap up, how would we in India use NIPT today? And I think the most important thing for us to understand, it is a screening test, but yes, it is a screening test with a high sensitivity and specificity. So I call it a high efficiency screening test, and it is only for the common aneuploidies. It does not screen for all genetic disorders. Pre-test counseling and patient-informed decision is the key to NIPT. I know there are limitations in our country, but it doesn't mean that we do away with pre-test counseling and at least allowing the opportunity to the patient to make an informed decision. We have to balance cost and the outcome of the test. Looking for one disorder which has a prevalence of 1 in 1,000 versus the cost of screening. It should not be that I don't screen for beta thalassemia because the family has spent all their money doing the NIPT test. It is important to understand that it does not exclude all genetic disorders or all causes of intellectual disability, because very often patients say कि बच्चे का तो mind का test हो गया था जी. I think the most important thing is to understand that one jacket does not fit all. The screening needs to be tailored to the patient's clinical situation as well as to the location where we are looking at the patient and where we are stationed within our country. Every screen positive test needs to be confirmed by the invasive testing. Once an NIPT shows a low risk, please do not repeat any biochemical marker or the ultrasound to look only for soft markers of aneuploidy, because you've already done the best screening test available. So we do have these two thoughts from within our country that are published pertaining to the Indian scenario. One in the Journal of Fetal Medicine, which is the official journal of the Society of Fetal Medicine. And this was once the 2016 update on ACMG guidelines for NIPT came up, and what were the implications for India. Now we would probably have to write one after we get the ACMG 2020 update on NIPT and aneuploidy screening. And the other one is in the Indian Journal of Medical Research on the suggested guidelines for screening for all genetic disorders, not just aneuploidy. And I think I would want to conclude by saying that FOXI and SFM need to draw up recommendations and guidelines for prenatal screening and provide uniform guidance to the obstetricians for the use of NIPT, as well as other disorders, including structural abnormalities like NTD and other genetic disorders like beta thalassemia. Thank you very much.
Thank you. Thank you, Dr. Ratnapuri, for this most delightful treatise on NIPT that I've ever heard in the world until recent times. It was extremely balanced, completely up to date, and made things very clear. There's been a lot of everyday problems in handling NIPT, and I'm so pleased we were able to use this correctly. And I do hope that when this webinar also joins the rest of our webinars on the internet, people will be able to use this as the referral book for what we do with NIPT in the next few years. Thank you indeed for that excellent treatise. There are a few questions. The first thing I'd like to announce, of course, is that we now do have a Society of Fetal Medicine Genetics Committee, which you are heading, and we do hope that we will get these guidelines within the few months that we have ahead. And I know it's a lot of hard work because, like you said, we don't represent a homogeneous population. We're terribly heterogeneous, and we really have to work on this very, very hard. If I were to look at the questions that have come in, the first question is it advisable directly to do NIPT? I know you have made this amply clear, but for those of us who joined in late, could you please re-emphasize whether I can just send off all of my patients beyond 10 weeks for an NIPT?
Okay, so let me start by saying that the new college guidelines say that you could do any form of screening or invasive testing for a couple. However, I think it's important for us in India to first start with a family history to understand the clinical scenario of the patient and the family, to do a first scan at 12 weeks, to look at viability, gestation, twins, and then decide which is the best form of screening to be done. Please do not use NIPT like we do, a CBC or a, HIV. It should not be added to the list of tests that are done in all pregnancies.
Thank you. That's a nice, straightforward piece of advice we all should be using. Second question is there any difference between monozygotic and dizygotic twins for NIPT?
No, because the NIPT is like your screening test. It cannot differentiate between twins. You would need to give the information because we do know sometimes the fetal fraction is lower for dizygotic twins. But otherwise, beyond that, you cannot differentiate which twin is affected if the NIPT comes back positive or high risk.
And then we have a third question relating to this, and that is that in terms of a vanishing twin, will a time gap of 6 or 8 weeks help in actually managing an NIPT a little later in pregnancy compared to the 12-week window that we're most comfortable with?
Well, yes, there is data to tell us that so actually the first thing is we should not do it when there is a vanishing twin. However, if you don't have an option, if it's a very, very high risk case and the family just does not want to do, even there you can't do traditional screening and they don't want to rely only on the ultrasound, then you would give a gap of 8 weeks before doing the NIPT. But don't be surprised if the NIPT comes back high risk as a result of the vanishing twin, because 50% of those vanishing twins are aneuploid. We can't hear you, Dr. Khurana. We've lost your...
Yes, sorry. Thank you for that answer. What gestation is ideal for NIPT? A repeat answer, please.
After the 12-week scan, make sure your baby is okay, does not have any abnormality, does not have a cystic hygroma sitting. So after the ultrasound.
Yes.
12
Now,
weeks.
we do have new protocols coming from various parts of the world which deal with an IVF population. And just like a lot of us have also started dealing a lot with the IVF population because this is an exclusive group of pregnancies that has their own problems. We're now beginning to do an ultrasound scan at about 10 weeks. And Monash in Australia does this as well. And in that, of course, if you find a structural abnormality, then you would suggest there is no question of then sending this, because actually it's called a pre-NIPT scan at 10 weeks. So if we find a structural abnormality, then of course we will not send it. And if we don't, then I guess they could. So
Yes.
is 10 weeks okay for the NIPT?
It is. It is. You can send it after 9 to 10 weeks.
And is there a BMI that we could possibly use as a guide that this patient should go later in pregnancy so that we don't get too low a fetal fraction?
I don't have a BMI in my head. I don't know whether you would, Dr. Khurana, for that.
Yeah.
But yes, as the gestation increases, the amount of fetal fraction does increase.
Yes. And there used to be a report a little while ago that if you do have this vanishing twin, then maybe an SNP technique might be better than an MPS technique. This was
SNP technique.
Yes.
So if we do the SNP technique versus the MPS, I really don't have an answer to that.
Yes, there were a few
I don't
publications.
know the reason.
Yes,
Yeah.
but
It could
they
be.
just disappeared from view. So I was just wondering why they disappeared.
I can't understand. The
Yes.
typical advantage of the SNP would be that it picks up triploidy, which the MPS does not.
Yes.
We cannot use SNP when you have an ovum donor. Okay, you can't use it in organ transplants. But I'm not very sure about this for a vanishing
Yeah.
twin. I've not read really. I don't know. I can check up.
Yes.
Yeah.
And that brings us to our next question. Are there different types of NIPT?
Yes, there are. There are three major platforms how NIPT is done. First is what is commonly available, and that is the massive parallel sequencing. That is, they just do a massive sequencing and they read off the 5 chromosomes. The second is SNP-based, and it could be targeted SNP-based where they do only the 5 chromosomes, or it could be a general SNP-based. And that is just what I spoke about a little while, just in my previous answer, that the advantages of SNP-based is that it will pick up triploidy that is not picked up by MPS. But in a SNP-based, it's very difficult to analyze the data if there is an organ transplant, especially by a different sex, so it will pick up the Y chromosome there, or if it's an ovum donor. So these are situations where you cannot use the SNP base. So the SNP base was really the Natera, but more or less I think that's not being used in our country anymore.
Yes, they've had trouble with finding a distributor, I guess, and that's been the problem. My other question that they want to know about is a good source for reading all about genetic tests for beginners.
Yeah.
I mean, do we really have a book anymore, or do we just attend our webinars and see what's on YouTube and take it on from there?
I think that's there, and plus the chapter of the book that you are taking forward.
I hope so, yes. I think that would be nice, and then we will see what we have to offer there. And the thing with books, of course, is, I'm sure you'll agree with me on this, that knowledge changes so much every day today in terms of technology, that a book gets outdated almost before it gets published. And so we really have to keep on updating.
There are basic genetic books. There are basic genetic books to understand. You know, what probably students use when they enter a genetics course. So they are simple to understand. But yes, they are there. Emery and Remoyne, and these are the common people, authors, where they are there.
Yes. And that brings us to this question on NIPT cost. We have currently on offer companies that say, okay, 35,000 rupees, and we will do A, B, C, D, the common autosomal trisomies, and we will give you the cats. We will give you the rats, the rare autosomal trisomies, and therefore we were doing a whole genome, which sounds so impressive actually, not realizing that the rats have actually confused us. And most of our rats have normal outcomes anyway. And then, of course, all the way down the list that you had shown us. So is cost related only to that, or is cost also related to the way these labs work?
So if there is one lab, the costs will never come down. The costs have come down in India because of competition, and I think competition is always very healthy. And obviously, if you don't understand what they are offering you, you would want the maximum for your patient. But at the end of the day, remember that NIPT is really for the 5 chromosomes, and that's all you need to do. You don't need to add on costs to look at the rare. They are so rare, those chromosomal aneuploidies, that you'll barely get them. And if you get them, then you will be spending more money of the patient to do the invasive testing for something that never needed to be done. So that's very, very relevant.
Thank you. There are some questions I think which we already clarified. Is microarray, does microarray give the same results as NIPT?
It gives
Well,
much more information. Yeah,
Yes.
it gives much more information. It's only, we do a microarray after invasive testing. If you've done a microarray, you've looked at abnormalities of number and structure of all 23 pairs of chromosomes. So it gives you a lot of information about NIPT. There's no comparison at all.
Yes. And can we use NIPT in RH status in current practice? And where in India do we find this service?
So most of the commercial companies are not doing it. We do it at Gangaram, but it's not something that can be sent because of the nature of the sample that is required. So we do it when the patient comes and we take a fresh sample. But it is difficult. It is not a very easy test.
It's not something that I would.
No, it's not very easy. Yeah.
Start with this
And I think
then
it's
move on.
better to genotype the husband to be sure that your baby will be RH positive, and then that's an easier method. If the
So the
if the
starting point
husband,
is completely
yeah.
different. Yeah. And then a reiteration of after doing an NIPT, in which case should I do invasive testing?
Every screen positive on NIPT needs an invasive testing.
Wonderful. And that actually brings us to the end of all the questions we have today. I'm sure there are more questions coming in because we had to shift over to Facebook as well because we ran out of space compared to what we thought we would be using. And thank you so much for being so patient with us and answering all these questions. Thank you indeed.
Thank you very much. Thank you so much.
I'd like to thank Foxy for collaborating with the Society of Fetal Medicine and being with us, and also to Core Pharmaceuticals for being there to support us. And over to Parth for final words.
Thank you, sir. Thank you, madam. Ratna madam, it was really very informative talk. There is a lot of confusion about NIPT, and sorry to say, but there is a lot of misuse of NIPT. So your talk was very clear. It was the things how now crystal clear. So I hope that this will help the clinician to understand and to implement NIPT in a better terminology. I would like to thank Ratna madam and Ashok Khurana sir for nicely conducting the seminar. I would like to thank Alpesh Gandhi sir and Jaideep Nayak sir, and also the Foxy Secretary Sunil Shah sir. Thank you very much to all.
Thank you. Thank you.
Thank you very much. Have a lovely day.
Thank you.
Thank you.
Take care and everybody stay safe. I think that's important.
Thank you, Dr. Ashok Khurana sir and Dr. Ratnapuri madam. Thank you, Parth, for managing everything on behalf of me.
Oh, I'm so glad you're here. Thank you.
Thank you, Ashok sir. I miss moderating you and madam's this thing because of some social reason. But I try to listen to the madam lectures and your question answer session.
Thank you.
Oh, thank you. Thank you for listening in. Thank you.
Thank you. Thank you, Parth, again.
Yes, sir.
Okay,
Bye
bye-bye.
bye.
Recording has stopped. The meeting has ended.